Right, we should have started recording now.
Yeah, it's live. Thank you. We'll just give everyone a couple more minutes, I think. We usually get more than 12, don't we, Lauren? Yeah. Trickling in.
Matt, I reckon we kick off, and then as people come, they
can
yeah,
just join.
I think we'll be okay. Yeah.
Right, good afternoon, everybody, and thanks for coming along to the Health Inequalities Learning and Action Group. Today, we've got a focus on hypertension, and we're very grateful for our speakers to come and talk about the various projects that have been going on in the city about that. Just a reminder that the session is recorded. If you don't want to be in, then please turn your cameras off. Yeah, Lauren and I will keep an eye on the chat, so if you've got comments to pass, then please put them in the chat or put your hand up, and then we'll have we usually earmark 20 minutes for a group discussion. We rarely get 20 minutes for a group discussion, but we'll do what we can to try and facilitate that. And usually we get some good stuff. My name's Matt. I'm a GP here in East Park, which is just east of the city centre. We're tucked in behind the Playhouse. And my kind of key areas of interest is health inequity and how we might ameliorate that across our city. Work quite closely, or have been working quite closely, with the public health team in the form of Lauren and Lisa primarily. And yeah, welcome everybody. It's nice to see some people who we know, and nice to see some new faces or new names as well. So welcome. Our first presentation today is from Hannah and Lizzie, who are talking to us about hypertension case finding in the community, and I'm looking forward to hearing what they've got to say. It's a hot topic at the moment. Everybody will be aware that cardiovascular disease is one of the biggest killers of. Is it the biggest?
Yes, I think it is.
Yeah, I think it's definitely top three.
Yeah,
it
definitely.
It takes bronze, silver, or gold. And so it's a very important topic, and it's hugely skewed with deprivation. You're much more likely to suffer from cardiovascular disease if you are from a deprived background. So yeah, a timely topic, and we're grateful to have you. So I'll pass over to you, Hannah and Lizzie.
Perfect, thank you. I am just going to share my slides. So just give me a little second. Lauren, will you just let me know that they're there and showing A-OK?
Yeah, we can see those.
Oh, perfect. Thank you. Okay, hi everybody, and thank you for having me here today to bring our learning from various bits and pieces that we've done across hypertension. But firstly, I'll just introduce myself, and then I'll hand over to my colleague Lizzie a bit later on in the slides. But yeah, I'm Hannah Kerr. I'm an advanced health improvement specialist in the public health long-term conditions team, and I have a role very much around kind of CVD prevention, long-term condition management from that public health perspective. We're also responsible for delivering and commissioning the NHS Health Check programme here in Leeds, and work really closely with the GP Confederation on that. And as part of that portfolio, we've got a big priority, and are really committed and dedicated to raising awareness of high blood pressure, and really contributing to finding those people that are living with undiagnosed hypertension, because as Matt mentioned in that introduction, you know, it's quite often a silent thing, but a big contributing risk factor to big cardiovascular disease events and conditions. So over the years, we've worked in partnership with lots of system partners to deliver a number of initiatives for this. And along the journey, probably over the last kind of at least 7 to 8 years, we've delivered lots of different projects in the community, in workplaces, and we've gained a huge wealth of insight that really kind of informs and contributes to ongoing development of this programme of work. So I'm just going to take the opportunity to share some of those with you. So my slides are going to really draw on a number of different projects, and not individually, but kind of collectively across these areas. So I'm going to reflect on a recent piece of work that was done in Seacroft and a blood pressure project. And my colleague Lydia, who is in my team but not currently at work, she also did her Masters in Public Health dissertation on this area of work. So we got some really in-depth qualitative insights that we want to share with you. We're going to reflect on some community BP grants in the inner South Leeds that Lizzie is then going to go on and develop and talk a little bit more about how we've learned and developed that piece of work. We've also got the NHS health checks that we've recently been delivering in community settings, and we know that blood pressure testing has been a big part of that. So again, really valuable insights gained. And back in 2018, we did a Blood Pressure Wise project, and that was really focusing on workforce and going into workplaces and really targeting those areas of health inequalities. So just touching a little bit on that kind of workplace perspective, because we know that's got a really important place. And we're really fortunate to have our Leeds Health Awareness Service in the city who's out there doing blood pressure testing out in the community. So just to run through the Seacroft blood pressure project that Lydia recently worked in partnership with, and the project aim of this was really to get out there in the community and raise awareness of high blood pressure, and really speak to the communities about what blood pressure is, and look out for those signs and symptoms, but really use an integrated model of care and support people that had initial high readings to kind of go on and take action, and a really person-centred kind of holistic approach. And as I mentioned, Lydia did actually undertake her dissertation and gain some really in-depth qualitative insights. As part of the project, we worked really closely in partnership with Seacroft PCN, and the We Are Seacroft partnership, which included Space 2 and LS14 Trust, and it was a really brilliant piece of work. It supported people. The organisations of the PCN went out into the community, really had holistic quality conversations, carried out initial blood pressure testings out in their own settings, out at different events, and then really supported them to kind of go on and seek that next level of support, whether that be through the PCN or through the pharmacy or through whatever kind of that person really wanted to do. But the PCN also did some really proactive case finding, and they looked at their clinical register and use high risk factors to kind of contact people and invite them in to have that blood pressure reading, to try and engage in that way. So what worked well and what did we learn from that piece of work? We instantly knew, and we get this feedback all the time, that members of the community really value having the opportunity to have their blood pressure taken out in the community and supported by somebody that they trust, and they have that really kind of good rapport with, and kind of relax and ease into that conversation. The third sector organisations took an initial 150 BP checks out in the community. And 13% of these presented with that initial high reading, and actually were signposted and supported to go on and receive home blood pressure monitoring through the PCN or through the pharmacy. The third sector organisations also, as part of that piece of work, and it was really important to not just focus on the readings, but actually have that broader awareness raising strategy, and they developed a really strong comms and marketing approach where they did really strong social media communication, raising awareness of the signs and symptoms of high blood pressure. They developed and produced a radio podcast. They did some advertising in their local newsletters and really got out there to their communities, signposting, raising awareness, telling them about the events that they were holding. And, you know, the outreach of that, you know, was over 30,000 people, which is just huge. So hopefully, you know, that making every contact counts just kind of drops that little thought in people's mind. And the PCN proactive care, like I mentioned, they did some clinical system searches, proactively contacted people via the phone, but they also went out into the community and worked with the third sector partners and carried out initial BP readings. And you can see there that they delivered 388 initial readings at community events and supported people to have that reading. And what was really brilliant about this piece of work is that we were able to kind of follow these people through that journey. So from that initial reading, they were then supported to access home blood pressure monitoring, and then people were followed through the GP practice, and 11 people were formally diagnosed with hypertension, and then receiving that treatment pathway to optimize that, which is you know, really important, and we can support them people going forward. So as I mentioned, Lydia, you know, she lived and breathed this piece of work, and she was really interested in, you know, that doing her MPH dissertation study, you know, presented us with a really brilliant opportunity to build that evidence base. And she aimed to explore the experiences and perceptions of those people receiving the blood pressure testing out in the community, but also the experience of the professionals that took part in this piece of work, because it's always so important to understand it from their perspective as well. She carried out 18 really in-depth interviews with people that had that blood pressure reading. So there were 16 recipients of BP testing, and then really 2 in-depth interviews with the sector professionals and some of the PCN staff as well. And as part of her dissertation, she formulated 3 research questions, very much looking at how is community blood pressure testing perceived and experienced by the public? What does it mean to them, and how do they want to have this delivered? And how this may then differ from other experiences of blood pressure testing. You know, is it different? Do they want it out in the community? That kind of thing. And it was also then really important to understand the perceived role of the third sector organisations in some of this work out in the community, how they foresee they can have a role around, you know, health and facilitating that conversation, both from a public and professional perspective. So from the interviews, Lydia identified that there was 3 really clear themes that emerged, and really high acceptability of community BP checks, and really driven by the convenience and relaxed nature that community settings offer for people. And as I mentioned before, that trust and connection with people it is really important. So trust as a facilitator for going on and having that BP check is really valuable. But also there was a really strong theme around unique accessibility of the BP checks in community settings, and how it really opened that opportunity for having wider support and that holistic conversation. So actually, you know, the BP might have been that initial conversation, but then maybe opened wider conversations, you know, from social and wider determinants perspectives. And then the third sector organisations were able to help support and signpost to the right places, but also offer that support from a health perspective as well. So from that piece of work, the main recommendations, and very much what we've taken into kind of future planning of these programmes, is that, you know, a trusted, familiar workforce to deliver BP checks out in the community is really important. But also to enable those professionals to do that, there needs to be really tailored training to support those individuals, to build their confidence around using the language to support the community around high blood pressure. I think some people often see high blood pressure as quite clinical, so building the confidence of professionals to really build that into their everyday conversations was really valuable, and they recognised that was a huge strength of this programme. And just from some of the data, we know that males are quite often a high-risk population, and used in the community. And by working with the third sector, we're able to reach some of those populations and really, get to some of those populations that we might not be reaching in other settings. So that was a really important finding and recommendation to actually, consider how and where we're reaching these people. So the next piece of kind of blood pressure testing that I kind of want to reflect on is the blood pressure wise workplace BP testing. Community is so valuable, and we've definitely learned that from the insights that we've got. But we know that actually a lot of our populations are in work, Monday to Friday, different times of the day. So going into workplaces felt like a really good opportunity. And back in 2018, we had the opportunity to work in partnership with the British Heart Foundation to deliver some workplace testing and having that really health inequality focused. So we worked in partnership with 6 pharmacies out in our deprived areas. But then we also worked with Leeds City Council, really trying to target some of those kind of routine and manual workforces that might not be able to access, your healthcare services and some of the community settings. And we were really fortunate to work with Leeds Community Healthcare to train up a blood pressure champion to kind of rotate around the different services and settings that we've got across Leeds City Council and do those initial BP readings. As you can see, it was targeted at men, but lots of females were reached. But when we were doing readings on men, their readings were initially higher. So we were then able to offer that ongoing support. So again, home blood pressure machines were monitored, given to these people, the returns back. And then again, it was linked into the clinical system. So that follow-up support was given. And as part of the evaluation, 43% of the people that had that initial BP testing kind of reported that they probably would have never had that blood pressure test done. They wouldn't have accessed other places. It found that 72 people from that piece of work went on to receive a diagnosis of hypertension. It was across a 2-year period, so it's a much longer period of time. As you can see, it's a higher number, but yeah, it was a really well embedded piece of work, really successful. We really wanted to expand that piece of work, but unfortunately then COVID hit, so people were no longer in the workplaces, and we were not able to continue that. But I think it's a really important learning for us going forward for how we get into workplaces as well and alongside the communities. And yet we've got, we're really fortunate in Leeds that we've got the Leeds Health Awareness Service, who is a community-based service focused on reducing health inequalities. So they go out and have lots of really good quality conversations about long-term conditions and cancer. And they use blood pressure testing as a really good engagement tool. And that's something that, again, we regularly seek feedback on.
I'm just going to give you a little timing nudge.
Yes,
because you've got a few minutes, so I'm conscious that Lizzie wants to come
yeah,
in.
I'm literally just going to hand over now, Laura. Thank you. So yeah, we've also had the opportunity to do some community BP grants in South Leeds, and that's what Lizzie is going to talk a little bit about now and provide a bit of an overview of that piece of work. Am I okay to hand over to you, Lizzie?
Yeah, of course. Hi everyone, I'm Lizzie. I'm a graduate management trainee working at West Yorkshire ICB in the Leeds team on the community blood pressure transformation project. So we ran a programme in 25-26. This was a community-led blood pressure monitoring and awareness programme launched in Inner South Leeds, West Leeds, Woodley and Hull Park and Morley District. The aim was to tackle CVD and hypertension inequalities, focusing on high-risk groups. And this was delivered through VCSE organisations in those trusted community settings. Funding was through NHS England's Health and Growth Accelerator programme, which is all about trying to get people back into work and healthy in work. And given that CVD is one of the leading reasons why many people are unable to work, it felt like a really good use of money. So we set an internal target to deliver 5,000 blood pressure checks and identify 350 cases across a 6-month period. Alongside this, we kind of wanted our community organisations to think about awareness raising and that broader kind of improving people's understanding of blood pressure and why it's important. And we supported our organisations through structured training, a clear pathway, and robust data collection. So I'll just quickly, just the next slide, please, Hannah. This is kind of like the pathway we gave our organisations. The key part for us was around the onward referral for those individuals with that first reading of high blood pressure. So the two options were either referral to Lincoln Leeds or referral to community pharmacy. So the community pharmacy option would follow that hypertension case finding service pathway, which I'm sure you're all familiar with. And then the referral to Lincoln Leeds was a bit different because it included social prescribing options, but again, enabled that opportunity for ongoing monitoring and support, individualised support in that non-clinical setting for people who need to then go on and see their GP. Next slide, please. So here's just one quick case study that we got from one of our organisations. This is one of many, which I'm sure I could share with you all at a later point. So there was a woman aged over 50 who attended 2 blood pressure clinics at the Gurdwara. At both of these clinics, her readings was high, and she was advised to make an appointment with her GP for further assessment. But this individual didn't feel it was urgent or was aware of the potential risk, and that first appointment, she basically refused. At the second time she came back, she reported feeling unwell and had trouble sleeping. Luckily, during this clinic, one of the project volunteers was a pharmacist who was able to speak with her in her mother tongue, spent time discussing her results and explaining the possible health implications of consistently high blood pressure. Being able to discuss this issue in her own language helped her feel more comfortable asking questions and expressing her concerns. And then by the end of the discussion, she agreed that she would contact her GP to arrange an appointment. And this case is just one of many that highlights the value of that culturally appropriate communication in communities that encourage people to take preventative health actions. Next slide, please. So here's just a bit of an overview of kind of the outcomes and impact in terms of identification and follow-up. So this data only is up until February, but it already highlights really kind of positive findings. We've already kind of overachieved in terms of that initial high blood pressure test being positive. And from early indications of our data in March and April, we've got very close to our target of completing 5,000 tests, which is really positive. In terms of onward referral, the most popular route was community pharmacy. There was still a substantial number who went through that Lincoln Leeds route. We do have funding for this for next year, so we are kind of looking at how we could improve the follow-up for those individuals who do go to community pharmacy, so we can have a bit of an insight into the data there and kind of what happens next for those individuals. Next slide, please. And then here is just a bit of a quantitative overview of the demographic reach. So in terms of ethnicity, we aim to test those from ethnic minority backgrounds. However, those predominantly tested were from that white background, as you can see. But this does closely reflect the Leeds population, that around 70% mark. And those several minority ethnic groups were represented in lower absolute numbers. Some were reached at higher proportions than the census representation. So yeah, partial but meaningful success and definitely good foundations to build on. In terms of those lifestyle and support characteristics, we had strong engagement from individuals who are smokers, carers, individuals with disabilities, and those with a family history of hypertension. We also reached a substantial number of people who were currently diagnosed with hypertension, which I guess wasn't our kind of original aim, but it does kind of highlight an opportunity for future years to kind of see how we could support those individuals through the community, because clearly there is that ability to reach them through these organisations. And then finally, in terms of gender split and age distribution, we reached a good balance of men and women, which kind of was in line with our aim of trying to reach men. And in terms of age distribution, our target was 30 to 65, and this was the majority of those tested, though the data was skewed towards that older generation. So we do want to look in future projects about how we can think about targeting those younger generations more. Next slide, please. And if you just click again. And in terms of outcomes and impact from that qualitative perspective, the programme reached people long disconnected from healthcare. There's lots of undiagnosed potential hypertension cases discovered. There's lots of examples of kind of carers and individuals within the community kind of working directly with primary care, which kind of serves to ease primary care workload. Lots of examples of that culturally tailored communication, which serve to break down barriers, as the grassroots example really highlights. And then finally, there's lots of examples of community connections that are being formed. Hold Back Together specifically have reported lots of new partnerships. Most recently, they've done some work with Leeds train station, which we've had lots of feedback about being really successful. Just next, please. And then just in terms of what we learned from that qualitative overview was that there were still a few individuals with that very high blood pressure who still declined GP follow-up due to fear, mistrust and lack of understanding, or even sometimes they reported some negative past NHS experiences. So this just kind of underscores the need to build that trust in NHS services, enhance that follow-up and monitoring so we can ensure people are followed up, and then also keeping those community settings as trusted points of contact, because there clearly an opportunity here to get into those groups that aren't normally accessing NHS services. Next slide, please. So common themes and what's next. I think the common theme across kind of all of these projects is that trust that people have in these community settings, the convenience of them, the work they do in supporting primary care access barriers, and finally the opportunity for reaching those working age people. I think the train station example is a really good one for that. And then, as I mentioned, we've got some funding for next year, and I think our key focus is first of all needs to be in addressing some of the operational challenges we faced this year. There were some financial process, staffing capacity challenges, so we really want to kind of like nail them down to strengthen programme delivery and sustainability. We want to focus a bit more on reaching all those intended target groups, specifically priority ethnic minority groups, and ensuring full coverage across the entire age bracket, specifically those younger generations. We want to establish a more consistent mechanism for supporting and tracking follow-up and monitoring patient outcomes, like after that initial test, making sure we have data for kind of what's happening next. And then finally, understanding and responding to that high proportion of participants this year who had a pre-existing hypertension diagnosis, including opportunities to align with the treatment to target work stream within the ICB. I think that's everything from us, but we'd be very happy to respond to questions when the time comes. Thank you.
Great, that's very interesting work that you've both been doing. So thank you very much for your presentation and for your hard work. I suppose the kind of like the question that I have, and I'm not trying to probe too hard, but you get to the point where the bottleneck remains primary care to a degree, doesn't it? You find all these patients with undiagnosed hypertension, which is great, and you need it, but they can't access the service that can treat their hypertension. So you talk about trust and lack of trust in the NHS services. People are right to be mistrustful of general practice because we don't have the capacity to see them. And your mild, moderate hypertensions in particular get a raw deal because our monitoring isn't as good as it should be and our engagement's not as good as it should be. And it all feels a bit frustrating. I'm sure you've experienced that as well, actually, from your perspective. The bit that I would find really interesting would be, and I don't know if you've got facility to do this, but to check in with those patients that you put in touch with the primary care services this year, follow them up in 12 months or 18 months and see how many of them are still on their antihypertensives. Because there's kind of and maybe this is a cynical approach, but we kind of think that if people want to take responsibility for their healthcare, they seek out the diagnosis of hypertension. And if they don't, and you go and find them and you tell them they're hypertensive, they then disengage later on anyway. So it'd be really interesting to see, is that something that you've been looking at? Could you follow up with these patients in a year to 18 months?
I think that's absolutely something that we would really like to do. And I think the connection via Lincoln Leeds was hopefully going to present and give us that opportunity to follow them up, because going through that route gives us that potential, because actually, you know, they've linked them in, supported them to access through primary care. So actually, they will then be able to follow up. So I would like to think that that is an opportunity that we can do, and that we would look to build on going forward.
Great. Well, we'll get you back here in 18 months' time. Claire,
There's
did you want to come in?
There's always complexities with data
Always.
and data
Always.
processes, but absolutely, it's the gold standard to do, isn't it? And we will seek to do it.
Great. Claire, did you have a comment or a question?
Yes, I just want to find out how did the GP practices respond to this? Because I think I've had it when we wanted to have when these grants came out for the community blood pressure checks. I had some feedback from within our area whereby GPs felt like it would be too much pressure. I'd like to find out what was the perspective of the GPs as this project was going on. Was there unnecessary pressure on the practices? Because as we get this initial test and then asking them to go to the GPs, I felt like at some point there was that pushback from GPs. I don't know whether you experienced it during that time.
I think the aim will be to, as we've got some more funding for the next year, is to really kind of engage with kind of GPs and like how it's felt to them in the past year, and then next year going forward, like how that will be, what like get your perspective kind of thing on how on the plans for next year. But yeah, it'd be really important to kind of incorporate the GP's perspective and obviously how this is impacting primary care.
Yeah, I think Claire was very gently edging around the fact that sometimes it feels like you're finding more work for us. Now, I think that's that, you know, and sometimes that's the feedback, isn't it, from GPs, is that when you're doing the right thing, absolutely, there's people out there who are dying from cardiovascular disease and they didn't even know it. But yeah, sometimes you'll get pushback from GPs for exactly that reason, that, well, great, now there's more work for us to do.
Yeah.
Right, we'll leave that project there if that's okay with you guys. Thank you very much for coming along and talking to us. Do appreciate that. And thank you again for the hard work in the projects that you've done. And now we've got Dr. Philip Zhu coming to talk to us from our Woodley Medical Practice about the community pharmacy case finding for hypertension. So welcome, Phil.
Thanks very much, Matthew. I'm just going to share my screen. Now, hopefully you can see my screen. So my name is Phil. I'm a GP. Oh, perfect. I'm a GP based in Leeds and in Old Woodley. I'm also have got roles within the NICE, the CQC and the Parliamentary Health Service Ombudsman. I sit on the Hypertension Transformation Programme Board as well as the Cardiovascular Disease Board for Leeds. But today, what I wanted to showcase was about the implementation of community pharmacy and how their role in the hypertension case finding service, as well as some of the data that they have generated, as well as some of Old Woodley Medical Centre's own experience of that with a neighbouring pharmacy practice and how our workflow changed. Now, you may ask in terms of why involve the community pharmacy in the first place. And as we've heard from Lizzie and as we've heard also from Hannah, in terms of it's all about down to the convenience in the community settings. It's about the relaxed area, and it's about trusted facilitation, really. And certainly in terms of community pharmacies, these are trusted cornerstones in a large area of Leeds. Certainly a lot more of them than GP practices themselves in terms of physical landscape. Now, one of the reasons why hypertension was chosen as one of the parameters for case finding service is the fact that, as Matthew alluded to early on with the WHO chart, it is a top 3 killer nationally for ischemic heart disease and for general cardiovascular disease. And of course, hypertension plays a huge role in all of that. And that's why the NHS long-term plan places such a huge emphasis on cardiovascular prevention. The other important thing to note is the fact that this is it's like a screening. The reason why screening is because with hypertension, very rarely do you get symptoms. And obviously, if you do get symptoms, often it's far too late and you have a lot of the complications sequelae beyond. So that's why we're talking about the specific service based at the community pharmacy level. One of the strongest public health arguments, I would say, for delivering this type of service through pharmacies is the equity of access. Now, we know the fact that pharmacies are more physically accessible than other parts of the healthcare system, and we do know that roughly 80% of people live within a 20-minute walk of a pharmacy, and certainly access is stronger than that in the deprived areas of Leeds. And we do know the fact that hypertension as well as cardiovascular disease is not evenly distributed. By that I mean people living in more deprived communities are much more likely to have high blood pressure and much more likely to have earlier cardiovascular illness and have complications from that as well. So if we wanted to reduce inequalities, then we obviously need some sort of a screening or a prevention service targeted or have the ability to scale in those same communities. And certainly what we found within community pharmacies is they have the reach and they have the capacity to do so. Now, to go through the logistics of the service in a bit more detail at the Leeds level, the headline message is that there's already a delivery platform. In Leeds, 150 pharmacies are participating in the programme, which covers just under 95% of all community pharmacies locally, and that's a huge asset. The delivery, they are delivering the program actively. The pharmacies that are not delivering the program are often because there's a community pharmacy just down the road who is delivering the program, so they don't want to become competitors, and or they're from the same branch or same multiple chain in terms of a provider. In practical terms, the service is aimed mainly at adults aged 40 and over who do not already have a diagnosis of hypertension, although certain younger adults may also be included in certain circumstances, such as a family history or a GP referral for any age. A patient can also come in opportunistically, or they may be flagged up by pharmacy staff as well. And the pathway itself is relatively straightforward. So the first step is a clinic blood pressure check with the blood pressure monitor. If the reading is raised, so between 140 over 90 and goes up to 179 over 119, then the patient is offered ambulatory blood pressure monitoring within the same pharmacy to confirm whether they have hypertension or not. And if unless the reading is over 180 systolic, then that might trigger an urgent onwards referral. So there's already a clinical governance aspect of it set at a national level. And certainly for public health colleagues, what matters is that this is something that not just increases awareness raising, it is a fully funded NHS service right now, and there's a clear pathway into diagnosis as well. And so this is not just part of a screening program in isolation alone, it's part of an overall system. Now, this slide focuses on the ambulatory blood pressure monitor, which is one of the most important parts of the service, because obviously if you do have an isolated high blood pressure on a one-off reading, you want to confirm it in terms of actual diagnosis. So a one-off reading is useful, but is not a diagnostic by itself. And obviously we understand, even though it is a relaxed atmosphere in the community, sometimes people are anxious within these sort of settings and will have fluctuating readings. And this will help to provide a bit of confirmation before treatment or management decisions can be made. So as you can see, even if the average blood pressure monitor is normal when they do it in sequence, the patient can still be offered valuable public health lifestyle advice and reassurance. However, if it does confirm raised blood pressure, then the result would support GP follow-up and further management as well. So the ambulatory blood pressure monitor is a bridge between the pharmacy check and any further onwards management in terms of a service provision perspective. Now, this slide highlights the fact that pharmacies are not just offering opportunistic case finding, but they can actually support general practice directly. And we've heard one of our colleagues, Claire, was asking in terms of, is this going to add to additional workload? Certainly that is a risk, but also GP practices can refer patients into pharmacies for a clinic blood pressure check or an ambulatory blood pressure monitor using any local arrangements that you might have via email, text, or any verbal handover where appropriate. And this matters because we have finite capacity within the GP workforce, but if we include include the community pharmacies as part of a wider primary care capacity rather than any separate activity happening in parallel, it gives practices another route for follow-up when they do need blood pressure measured, but don't necessarily need to happen in the surgery itself. And also, as we seen in terms of location-based, it makes the patient journey quicker and much more convenient as well. Now, in terms of the national setup for the hypertension case finding service, it does follow the NICE guidelines in terms of the preferred way of confirming likely hypertension. So we see that entry point is under section 1. They have the clinic blood pressure check in the pharmacy itself. And then if it is elevated, they're offered an ambulatory blood pressure monitor at stage 3, unless they're very much escalated, in which case they can be referred more urgently. This slide summarizes the finding of Alwoodley Pharmacy, which is next door to Alwoodley Medical Centre, from a sequence of 3 months of readings. And they carried out 286 blood pressure checks. And what's interesting is the fact that 40% came from GPs in terms of GP referrals, 40% were identified by the pharmacy itself, and 20% were self-referred by the patients themselves who've gone in and asked for a blood pressure check themselves. So it certainly tells me the fact that the service is functioning in different ways. It is supporting the GP practice, and it's also generating its own case finding opportunities as well, and also attracting patients directly in terms of the need. Also think about, in terms of the opening hours, the GP practice, we don't open on Saturdays, but the pharmacy next door, they are open on the Saturdays and the weekend as well. So that, and also late evenings too throughout the working week, and that can widen access to people who may need it the most. The clinical yield is interesting. 18% of the people screened from the case finding needed ambulatory blood pressure monitor. And of those checks, a meaningful proportion was then found to have either stage 1 or stage 2 hypertension. And around 8.4% of those screened fell into those categories. And in other words, really, it's not terribly low yield. It actually does yield a meaningful number of patients. And that tells me the fact that a significant minority of people coming through the door are being identified with blood pressure that's high enough to justify this ongoing action as such. And hopefully for places like Leeds, examples like this, it's put into data, and in terms of number format, it actually highlights the fact that this is visible on the ground. So this data was done in 2024. We've repeated the data, which I've not shown you it'll be later on, but it'll be in 2026 of January to March, 3 months. And again, what we found is that there's a 50% increase in the number of blood pressure that's been taken. So certainly patients are accepting of this, and this is just from one pharmacy in Leeds. Now, how is it all funded? Because, it's important for activity to be matched to any sort of funding mechanism. And this is fully funded by the NHS. And it is set up because pharmacies get off a one-off setup payment, and they have a payment for each clinic blood pressure consultation and a higher payment for each ambulatory blood pressure measured that they do. And obviously ambulatory blood pressure measurement reflects the fact that it's much more resource intensive. Pharmacists may be adding up and doing the averages and processing the administration aspect of it and forwarding any necessary report and results, even if it's normal, to the GP practice, which we actually find quite valuable, because then we can code it into our system to denote an annual blood pressure check as one actionable example. And or because they've done the ambulatory blood pressure monitor, we can then move on to management, etc., or blood test without needing any of the pre-work that's already been done. And again, for the public health colleagues, this slide about funding prompts a broader question. If we do want to maximize population impact, you can see that in this funding mechanism, they're paying for activity levels. And obviously one wonders, in terms of the locations of the community pharmacies, where the service is being used and where the service has been highest. Now, this slide brings back to the public health issue, which is inequality. And in Leeds, we know that, a quarter of residents live in the most deprived 10% of the area nationally. And that's a quite significant proportion of the city. And that's obviously, as we alluded to before, tied to cardiovascular risk. So the message here is the fact that with a universal service, which is acceptable to the patients, as we've heard from Lizzie, a blood pressure check in a deprived community is not just a transactional nature, but it can really be used as an intervention against any health inequality as well. I've told you that's 150 pharmacies within Leeds. These are spread on the right-hand side in terms of the split. I'm going to show you a strata map of the community pharmacies split across Leeds. And as you can see, in terms of these are all the numbers of community pharmacies who are doing hypertension case finding service. The color coding denotes the numbers within circles, denotes the number of community pharmacies in that specific area that's shown. You can see in the gray letters where it says A, these are specific community pharmacies which have submitted 0 hypertension case finding blood pressure monitor in December 2025. But once you zoom into the data, once you zoom into the location, you'll rapidly realize that these are, there are multiple community pharmacies in that same stretch of the road who are offering the service instead. So they probably took a business or financial decision not to partake in that activity. But there is a good geographic spread across Leeds, and you can see, I've cut this stuff off on the north east aspect of it, but there are areas there which are covered too. In terms of overall numbers, the raw numbers show that in November 2025, there's about 6,000 blood pressure checks, clinic plus ambulatory, in 1 month across the whole of Leeds. And if you take a look through the various PCN splits, this is just based on community pharmacy, you can see that the service delivered more than 53,000 blood pressure checks and over 5,300 ambulatory blood pressure monitors in those period alone. And that's a substantial volume of activity that is being carried out. And if you can imagine, each of them is a 10-minute HCA appointments. That is a significant amount of primary care resource time that's being saved. And from our perspective, we felt that it'd be so useful, even if the blood pressure is normal, for the report, for the reading to be passed on to us, so we can then be coded onto the system so that we know that patient has had a normal blood pressure at this time point, which may then save us another appointment down the line if there is any sort of annual review of any checks for anything that they might need to do. And again, you can see there is a variation in activity level, and that can maybe highlight, there are areas of good practice that we can learn from community pharmacies in those regions, and or maybe service provision can be strengthened in various PCNs within the community pharmacy setup. So this highlights a bit of activity reports, and it also highlights the areas of, I guess, the need and the demand for the community blood pressure hypertension case finding service. Now, this is just a photo which just shows how community outreach events, as Lizzie said, is so important, and they create opportunities to bring case finding into trusted environments. So community pharmacies themselves, they go into community centres in the local area where they're geographically close by to the community pharmacy themselves, faith settings, charity events, workplaces, and certainly they do promote this as well in the local region. So again, hopefully that helps again as another pathway, another mechanism, another lever in terms of the outreach. And what I would say is the fact that in terms of reporting into the GP practice, it only achieves the full value if there is sufficient information flow that goes into the GP practice, which is the right place and leads to action. And certainly, they are using GP Connect and other similar digital arrangements, which reduces the amount of friction in terms of coding and in terms of getting the various data that needs to be gotten into the GP practice. And so that means that the blood pressure data can be sent reliably, and then that means it can be coded by the admin staff, and then that means that the workload for follow-up, etc., is a lot less. And as you can see, when 40% of their workload comes from GP practice directly, we're actively leveraging the nearby pharmacies to be and utilize them for hypertension monitoring, as well as screening as well for patients who may need it, just to give community GP practice a bit more capacity as well. So you can see, there's a couple of points to mention, is the fact that we know that hypertension is a big driver for cardiovascular disease. It contributes to a large number of preventable, avoidable illness. Secondly, the fact that there's a large number of community pharmacies already in Leeds that has really got clinical governance in place, or has got a funding mechanism in place as well, that does a significant number of delivery of blood pressure monitoring already, and certainly it's got some some highlights are it's got strategic value. I've highlighted data from the local pharmacy to Old Woodley, but also across the leads, across all the PCNs as well. And certainly, hopefully, that will result in more preventable cardiovascular events, shifting the care to the neighborhood as well. And maybe, I might convince you, Claire, it might ease a bit of pressure on general practice and certainly narrow health gaps. Either way, the funding's out there, and I can see from the medium-term plan from NHS England, they are pushing more of the care on community pharmacies. And as GPs, as primary care, we have to be able to utilize that as a service because it is a funded service for the benefit of the patients. And that's all my talk. So back to you, Lauren and Matthew.
Oh, thanks very much, Phil. That was a really slick presentation, and thank you. It's actually nice because well, those of you who work in primary care will know we actually get a fairly high volume, as you can see from those numbers, of reports of blood pressure. And it's interesting that, and Phil, you raised a really interesting point, that it doesn't feel onerous, because usually those are the patients that we would have been seeing anyway, and it comes with a report that's really clear about what their blood pressure is and then what they're, and because a high proportion of people who have a single one-off reading of high blood pressure will need to go on to have some kind of home blood pressure monitoring. And by the time we get the information from the pharmacy, most of the time that step is already taken care of. And what we like to do in general practice is quick decision making. So the pharmacy provides enough information that we can make that decision very quickly. And it's actually been a really useful service, and it doesn't feel like it's adding to our workload, because like Phil said, they handle the ambulatory blood pressures too. Interesting to see how it's paid, Phil. That's less money than I thought it would be. Is that still financially viable for the pharmacists? I mean, lots of them are doing it, so it must be, but £10 per blood pressure doesn't feel like it's particularly high.
That's true, Matthew, but we got to encompass that in terms of other activities they may be doing. So they are opportunistic. So obviously, if they do, and there's not delivered by the community pharmacist per se, it could be delivered by a pharmacy technician as such as well. And if they are doing something like pharmacy first scheme as well, and they are doing a blood pressure monitor at the same time, then obviously that couldn't be incorporated in terms of their activity levels. So, but certainly it seems to be financially enough for them to be providing this model. And as you can see from the pharmacy next door, who's doing just under 400, which is about 130 per month, that's times 10, that's about 1,300 per month of income for one pharmacy alone. That is quite substantial level of income for them, and that's just blood pressure, not even accounting for the ambulatory blood pressure component of it as well.
Yeah, fair enough. I mean, our pharmacy is attached to our building, and sometimes they will walk the reports round and talk it to us if it's sufficiently high, and it's actually been quite a useful bonding tool. We feel like we work more closely with them now, and it's improved our relationship as a result, which is really, really nice. Great. Is there any questions or comments from anybody else? Super. The data that I shared from the World Health Organization is actually from 2021, which is frustratingly out of date. There is data from 2024 about leading causes of mortality, and I can't remember which one, but it's still up there in the top 3 of cardiovascular disease. It's interesting. You from the project that you guys talked about, Hannah and Lizzie. You mentioned symptoms, but I mean, I guess blood pressure is famous for not causing any symptoms. Did you find that people present with symptoms? Do they talk about that a lot?
I think I don't think people present about symptoms, but I don't think they know anything about high blood pressure and about anything that could be associated or even make them think that they may need to go and get checked and tested. But Lizzie, your case study did reflect an example, didn't it, of kind of linking something together with that as a sign and symptom?
Yeah, there's been a few case studies where I think people have mentioned symptoms like following their tests. I don't know if it's kind of got them thinking. We don't know it's necessarily related, but yeah, there's quite a few case studies where people talk about symptoms once they've kind of had their test done.
It's interesting because we'd be very quick to dismiss that in general practice, but actually maybe that our understanding is slightly wrong, because we will hear it a lot. People talk about they think it's their blood pressure. We usually kind of laugh it off, but maybe that's not fair for our patients. Phil, I just wanted to comment on the volumes. So BHR is the biggest PCN by a substantial way. It's close to 100,000 patients in the patch, and their numbers for the uptake it's high, but it's not relative. It's not proportionally high, and it is the most deprived or second most deprived PCN. Any clues why that's? Because that would speak to widening a gap rather than narrowing it. Any clues why it might be underperforming in BHR?
That's a good question. We don't know. We've just got the data in terms of the delivery, and obviously a lot of it stems from the fact that the patient needs to be engaged enough to cross the threshold into the community pharmacy in the first place. You can see there are actual events for them to go out to these various other community outreach places. But again, they do need, even though there are a number of community pharmacies in those local areas, the patient does need to go through the threshold. So if the patient do not engage with healthcare systems or pharmacies, then it's difficult for them to screen them in the first place unless you go to the neighborhood and the areas where they might be for other occasions as well. But yeah, I agree. The numbers doesn't reflect really other locations, and certainly it's something that highlights a bit of inequality and maybe more targeted focus on working with Community Pharmacy West Yorkshire in those areas specifically.
Yeah, well, I wonder if there's some collaboration about to happen here, Hannah. Is that what you're about to come in on?
Yeah, we've got quite a historic relationship with West Yorkshire Pharmacy, because there's absolutely, opportunity for collaboration here with the community testing and linking into the community pharmacy. And another project that we did a few years ago that I didn't touch on was where we worked in partnership with West Yorkshire Community Pharmacy, and some of them supported the community events, came out and really handheld people along that pathway. We did often get feedback that although the pharmacy that was signed up wasn't necessarily the pharmacy that people went to, so there's just lots of complexities, but absolutely moving forward into the next phase of the community grants programme. We recently had a conversation with West Yorkshire Pharmacy to see how we can really strengthen that pathway and see if there is more that we can do, because interestingly, your data showed that, Lizzie, didn't it? That's where people said that they wanted to go. It'd be really interesting if people were signposted. Did they actually go on to attend that pharmacy? And we were looking to see if there was some kind of pathway that we could put in place to try and track that through. So yeah, absolutely something that we're looking to develop going forward.
Great. Well, that probably brings us to the end of our meeting today. So thank you everybody for your attendance and your input. Our next meeting is 17th of June, as you can see there on the screen. The new health inequalities specification and fair practices. So I'll very briefly touch on what this is. A GPOP for the next year, which is a funding stream for primary care. One of the potential projects is about reducing health inequity across the city, and part of the offer or part of the ask is attending this meeting regularly. So we will present a bit more about what that looks like at our next meeting. On that note, if you know anyone in your GP spheres who wants more information about what that GPOP looks like, and I'll be really honest, it's quite low-hanging fruit, this one. It doesn't require a lot of work to get the money. So if you mention that in your conversations with your colleagues, that would be appreciated. And otherwise, we'll look forward to seeing you in June.
Thanks everybody.
See you later.
Take care.
Bye-bye.
Bye.